Welcome to AETCM, the Emergency Medicine Channel. Shall we start? A 88-year-old male, known case of coronary artery disease, bronchial asthma, dyslipidemia, CKD, CA bladder post TURBT, presented with complaints of inability to reinsert the foreskin onto the glans penis. On initial 10-second assessment, airway was patent. Breathing.
Should you really check airway breathing circulation in this patient?
Only just BP.
So we can directly
go to this. We didn't take any adjuncts also. VBG point of care we didn't take.
There is no indication.
So coming to history, 88-year-old male, known case of CAD, bronchial asthma, dyslipidemia, CKD, CA bladder, post-TURBT, presented to ER with complaints of inability to reinsert the foreskin onto the glans penis after retracting it. He had a small ulcer over the sulcus and used to apply soframycin ointment over the site. Since few hours, he was having entrapment of the foreskin. There is no history of any fever, any urinary retention, any discharge, penile discharge. And
why that is important?
Any UTI or balanopostitis causing the
correct
paraphimosis. And there is one similar episode in the past which required dorsal slit.
Okay. So he already had a surgical procedure for the same complaint.
Right? So coming to local examination, foreskin was found to be trapped behind the coronal sulcus with edema of the foreskin, and penis was soft but tenderness was there.
Why that part is important? You told penis was soft.
If there is penile ischemia, it will be hard to touch.
Yes, penile ischemia, that's how we can rule it out. Early phases of penile ischemia, penis become very hard.
Very hard. Right. There was no constriction bands or tunicae present. There was no skin changes over the penis.
Okay.
So we came to a diagnosis of paraphimosis.
Okay.
So initially we had kept a gauze which is soaked in 3% saline and lignocaine jelly over the area.
Why?
To reduce the edema.
So initial step is to try to reduce as much as edema possible and achieve
pain relief.
Analgesia. So analgesia you can either give us
either topical lignocaine jelly we can give, or else we can give procedural sedation, parenteral
IV analgesics or procedural sedation can be given. IV analgesics would be more than enough if it is reducible, right? Okay. Now in this case, most important stuff is the initial decrease in edema. How do you achieve that?
Either we can use hypertonic solutions over the area, or granulated sugar we can put over the area.
In hospital?
Hypertonic saline goes soaked in hypertonic saline, either mannitol, 3% saline, dextrose.
Any hypertonic this thing is solutions are fine. Easily available solution can be used as per the institution. 5% dextrose, 10% dextrose, or 3% saline. All these can be used.
And then we can keep it for 15 to 20 minutes for
no, that's the important thing. So if you're keeping it, don't just apply it and in 1 or 2 minutes remove it. You need to give it some time. So once you apply it, you can wait for 10 to 15 minutes. Then you have to reassess to see whether any improvement is there, right? How will you know whether improvement is there? Edema. First, visually you can see something. Otherwise,
we can just
you can attempt to reduce. So if it is getting much more easier, you know that edema is getting limited. Okay. So that is the first thing. So initially itself give lignocaine, topical lignocaine as ointment for the local area, and anti-edema, osmotic anti-edema measures can be given. Okay, then how will you reduce? What is the first steps of reduction?
The steps of reduction, first initially we have to hold the penis with a gauze with a minimal amount of lignocaine, and then hold the penis with both our hands. That is, the thumb should be on the glans penis, and with the shaft should be hold between our index and middle finger. And with the pressure, like with thumb, we should push the glans inside and the foreskin at the same time to pull out.
Constantly pull the foreskin forward while pushing on the glans penis. The idea is to exert a constant pressure, not sudden jerky movements or pulling as such. Slowly, constantly keep pulling the foreskin while keep pressure on the glans. Okay. So this is what you do. So if you are trying it for the first time and it's not reducing, what do you do then? Or will you repeat it? How do you proceed then? First time you tried, you gave the osmotic anti-edema measures and all. You tried, but it's not successful. What will you do?
We can attempt once more after reassessing the edema.
Yes.
And if second time also it is not, we have to call our surgeon or urologist.
Okay, so how do you attempt second time? Like first time it's failure, right? What else will you do for the second time?
We can give an analgesic more, or else
Analgesia
then
is pain. Failure is not secondary to
an
fail.
edema we can.
So, what else you can try with a secondary other drug? If you already tried with 5% dose, you can use a 10% dose, or you can use 3%. You can use a much more higher osmolar substance to reduce the edema on the second day, and you can try it once more. And as we are already told, if you are able to reduce it much more than the initial time, it means that edema is coming down. So you can always wait. So when will you not wait? Or first time you tried and it's failing, or initially itself you don't want to go for manual reduction, or if you think manual reduction is going to be failed, in what condition is that?
If there is already ischemia of the
If you are suspecting penile ischemia, you should not wait for manual reduction or edema reduction. You should directly go ahead with intervention. So what is the intervention?
dorsal slit we can put, or else emergency circumcision.
Okay. So emergency circumcision definitely will take much more time, right? Because that's a operation theater procedure. So it's not going to be emergency. So you need to put a dorsal slit. So how do you put? You're putting a vertical or horizontal slit,
and then wait for, squeeze to get out the edema.
Yes.
And then try for reduction, and then suture the.
Basically, whatever we are doing is basically to reduce edema early. Initially, we try to remove the edema through osmosis, and that is not getting required. If that is not getting adequate improvement, we are putting a slit so that you can squeeze out the free water or edematous water and try to increase the laxity of the foreskin so you can pull it out. Once you achieve reduction of foreskin, what will you do to the slit?
Suture it.
It has to be sutured it back. And once sutured, you can give the option for the patient for
circumcision.
Going forward for circumcision, especially if it is multiple episodes. Like for this patient, already had one episode, one dorsal slit, now also he is having. So you can advise circumcision. And if patient is not willing, you can put the suturing and truss the area and refer send the patient back, right? Post procedure, do you want to keep the patient in ER, admit the patient, or keep in ER, or discharge the patient? How do you want to dispose the patient of?
If there are no further complications, we can discharge.
Okay.
If we suspect any ischemia or
ischemic part or persistent pain, then only you need to keep on observation. Okay. Any other? What is the most common cause of paraphimosis that you may encounter in your emergency?
After catheterization.
Yes. So mostly post-procedure paraphimosis is the most common thing that we may encounter rather than the community as such, right? So what is the reason? During catheterization,
we will retract the foreskin and we'll failure to.
We may forget to put it back in place. So always in forex catheterization, make sure that foreskin is retracted back. Okay. What is the most common lignocaine cream? You told lignocaine cream can be given. No? What is the concentration?
3%.
2%.
2%. Without adrenaline.
Without adrenaline. That is important. 2% without adrenaline. Any analgesics that you can use for the pain? Some of the analgesics you can give.
IV analgesics.
Acute procedure, right? What will you give?
Opioids.
Opioids. Direct to opioids you can give because short term, short procedure. Any complication as such?
Complications. Failure of the manual reduction is the main complication, and if then there will be any nerve injury can happen, dorsal penile, if we are.
So there is a possibility of giving dorsal nerve block for local nerve block for pain relief. But if done not by a properly experienced person, it can develop nerve injury causing
inability, impotence.
Impotency, erectile dysfunction. Other than that, it's a pretty simple procedure, right? Anything else to add?
Then differential diagnosis. That one tunicate syndrome is there in like infants or in mentally retarded patients. There will be like there will be some hair or any string of the means any cloth string or something can be tied around that. So tunicate syndrome present like paraphimosis. So if there is paraphimosis, just search for any tunicase there. If then just cut and then reduce.
Anything else?
Mm, I think so.